And welcome everyone to tonight's First Principles of Movement Student Working Group special event with our special guest, Ryan Chow. For those of you who are joining us for the first time, this group was established last summer with the intention of bringing together the next generation of clinicians. So everyone in the room tonight is a student, either a future PT or osteo or chiro. We've got a wide variety, and I'm curious to see who we have in the group. But the focus was to bring this next generation together to focus on the knowledge translation of the first principles of movement. If you are less familiar with what FPM is all about, we'll be discussing that in just a couple minutes. But again, we do invite you guys to turn on your cameras and actively participate through this talk. Again, the focus is knowledge translation, and that doesn't happen passively. So, utilize the chat function. There may be opportunities throughout that Ryan will stop to see if anyone has questions. So, so definitely encourage your participation. And since this is a fairly large group, go ahead and type your questions or comments into the chat just so we can make sure that we don't miss anything that you want to ask or that you want to contribute to the group. So before we get started, would love to learn about who is in the room tonight. So I'm going to copy paste a prompt into the chat, but basically if you can enter your program, so if you're a PT, chiro, et cetera, school, your location, because we have an international group with us tonight, as well as your graduation year. So if you would, everyone just type into the chat those couple of items, give us a good idea and give Ryan a good idea of who is here with us tonight.
Yeah, that's helpful to know the audience. Thank you.
For sure. I'm curious too. Woo.
UK in the house, Dallas in the house.
Arizona, welcome, Deanna. Yes. Woohoo, Columbia, Mandy. Awesome. As you guys continue to trickle in with where you're from and your program, Ryan, if you don't mind, in case anyone is not familiar with who you are and your background, do you mind giving a quick introduction?
Yeah, sure. I'm a FPM faculty member, but I started out as a personal trainer. So I'm born and raised in New York City. I'm still here. And I studied movement science at the University of Michigan, expecting to go to PT school, and plans got derailed a little bit. And I became a personal trainer for maybe 3 or 4 years before getting into PT school. And then I met Dr. Craig Liebenson while I was a student, and then I got introduced to his work in FPM. And after that, I became a physical therapist. I started practicing the way he was teaching me to practice. And I eventually opened up Reload Physical Therapy about a year after school. And now I'm just running this practice, teaching with Dr. Liebenson, and trying to help him update everyone's priors, ours first, and then hopefully to teach others what the latest evidence is and how to translate that into practice.
Great. Thank you. And I think you were speaking to it a little bit during your introduction, but for those who are less familiar with first principles of movement, can you give us just an idea of what FPM is all about?
Yeah, first principles of movement's about first principles. First principles is an idea that you kind of boil something down to its most basic parts. And for us, that's Dr. Liebenson, myself, and the rest of the faculty. It's about updating our priors, which means being humble and trying to stay on top of what the latest research is. And that means not having any dogmas around what is the best way to help people. And our mission is to stem the worldwide inactivity crisis. And what that means is, and this is for all professionals, whether it's, I see we have chiropractors, physical therapists. I don't think we have any trainers here, but and this is for coaches too. And we believe that movement is medicine, and we believe that uh, it's for the clinicians that see our clients, because inactivity is such a pervasive issue today. We have a very unique opportunity to provide the gift of injury for the patients that come across, that we meet, because we know that most people are not active enough. We want to turn people's injuries and pains and things like that into an opportunity to teach them how important it is to move for preventing chronic disease, cardiovascular disease, diabetes, obesity, arthritis, all these things that are uh, really plaguing the world today. Most of the money that we spend in healthcare today, in the US at least, is around chronic pain, musculoskeletal disease, and things like that. So we want to change those outcomes, and we want to uh, empower professionals to better do that. So that's who we are and what we try to do. And we hope that you guys find this interesting and find this mission that resonates with you, and hopefully you can come along and be a part of our worldwide community.
Great. And then I know that during your case studies, you'll probably speak to the gap analysis that's used to individualize the care that you're providing. Can you explain to us a little bit about what that gap analysis is?
Yeah, so the gap analysis we got from uh, we got from everyone from great sports scientists and coaches like Carmen Bott out of University of British Columbia in Vancouver, who works with Olympic wrestlers, to Jill Cook, who works with patients with tendinopathy in Australia. So this is just an idea where we truly believe that in order for us to help a person, we need to meet the person where they are, and that means we need to understand their story. We need to be like Peter O'Sullivan, who a physical physio out of Australia, who really believes in understanding the person in front of us. So we get to know the person, their story, who they are, what they're coming to us for, what their concerns are, what their beliefs are, and then we figure out what their goals are, and then uh, lastly, we figure out how much time is needed for that they expect for us to go from where they are to where they want to be, and little by little, we just bridge the gap between the two. So it's how we get around trying to fit people into our systems, trying to force everybody into the tools that we understand. I'm SFMA trained, I'm kettlebell trained, I'm this trained. So if I didn't have I'm physio trained. If I didn't have first principles thinking, I might try to force everybody to use a kettlebell and into a SFMA screen. Not that anything is wrong with either of those things, but not everyone's going to fit into that system. So when I try to put a cookie cutter onto a person instead of meeting them where they are, that's when a lot of people lose their sense of hope. They lose, um, they're no longer the center of their care. Instead of being client centered or person centered, we become doctor centered. We try to force everybody to do what we want them to do. We lose sight of their goals because we try to turn their achy back into a kettlebell swing session or whatever it may be. So the gap analysis is suspending our beliefs and meeting our clients where they are, and trying to listen first and hear out what they really need and want, and adjusting our programming to that. And sometimes that's maybe an exercise is great for them, but they have pain. A client might have pain in their office, and if I'm asking them to do a bird dog in the middle of the office, even if it helps them, that's simply just not something they might do. So that's not a sustainable solution for some people. So I need to understand all of the person's goals and all their barriers before I start saying, do this, do that. Like, sure, maybe they might feel great with a TRX exercise, but if they don't have a TRX and they're not willing to get one, then what am I actually doing besides forcing them to do something that they can't do? So, yeah, that's kind of a summary of where that comes from and what that is.
Great. That makes sense. And thank you. I think that's a really good overview of why, what FPM is about and what makes them unique, as well as the gap analysis that'll help us better follow the cases that you have prepared for us. So with that, I'll leave it to you, and I'm looking forward to learning.
Thank you. Do I have share screen available?
You do. It should be enabled. Let me know if you have any trouble.
All right. No, we're good. And just on that, just so you guys know, I'm with a training background. I have a bias towards training, and it happened to work out for me because right now a lot of evidence is pointing towards active care versus passive care because it empowers people and it allows people to rely on things that they might be able to do on themselves for themselves. But after maybe a year and a half of doing minimal manual therapy, I've been working with a client that's seen 7, 8 different doctors, gone multiple surgeries, and he's even seen some of my staff and some of my friends, and he's got no results. And just an hour before this, I did manual therapy on him, and lo and behold, we got better results than we've ever gotten. So it's always just a reminder to never lean too far one way or another, and just hear the person out. And who knows, maybe he just needed a little attention and wanted to be know that he was it was something I'd be willing to try to hear him out and things like that. Or maybe it was actually what he needed. I won't know, and that's kind of the problem with how we study interventions. But um, I just wanted to bring that up because I'm still learning to uh, I'm always fighting my own biases and trying to be as objective and person centered as possible. And with that, if you guys can see, can you guys see this okay? You guys hear me okay? Good. I want to just, originally this was titled case study because we do case studies and we learn from them. But we have a client that our team has been working with who has seen a lot of different doctors and has gone through a lot of chronic pain and disabling symptoms. And a lot of people have told that person that they're the most difficult case that they've ever seen. Physios and chiropractors and doctors have said that to them. And that person said that they felt like dehumanized. They felt like um, they weren't a person, but they were just another pathology or case or something. And that's why I'm updating my priors, and I'm not going to call people case studies anymore or name people by their what they're suffering or what part of their body is suffering, whatever their diagnosis is. And I want to highlight that this is person study, and we want to humanize our clients because that doesn't exist in today's burn and churn type of healthcare, where it's more about profits than it is about people. So this title is paying homage to that. And yeah, so that's where we're starting today. And I see there's a lot of chiropractors and physios. Are there anyone else? Is there any other profession that I'm missing here? Okay, I just want to make sure that terminology wise and language wise, I'm gonna keep you guys uh, as informed as I can about the terminology that's specific to the abbreviations I'm using. But if you guys have questions, feel free, type them in, and I'll pause a few times so we can discuss anything as we go. But feel free to write down any questions. There's no small or stupid questions, and I want to hear from you guys the most, more so than speaking myself. So I want to tell you guys about a client that I've had several months ago, and he came in with right neck pain, numbness, and tingling down his right arm. So I know there's a lot of chiros and physios, so this is something you guys probably see often. And it started 2 years ago. Uh, Sorry, it had started 2 to 3 months ago on the right side, but he had a history on the left side as well. So 2 years ago, left side, same thing happened. And that's a very scary thing when something like that comes back, and especially when it comes back the other side, because he had weakness in his triceps, numbness and tingling going down his left arm, and he had significant atrophy on his left side. So, the fact that this had been going on for 2 to 3 months was he was coming from a scary place. And just like 2 years ago, uh, this happened after Thanksgiving, and he worked at a bakery, and it was a 12-hour long day rush, and he had a repetitive handing of items and things like that. And both times that was when it started. It started a week or so after that had happened. And now at this point, because of it had been going on for all these months and he hasn't gotten any relief, he's been to different doctors, physical therapists, and things like that, and nothing's gotten better. He had gotten imaging. He'd been told he had a disc, and that uh, he's got he basically needs to get surgery. So he's scared of that. He doesn't want to do that. And right now, this pain is stopping him from driving for more than an hour. He wakes up with pain every day. He can't work at the bakery anymore. And even before that, he was a police officer, and he gave up his police officer job and went to baking, which to you guys, I'm sure this sounds crazy, is he gave up such an active job. He was a pretty active police officer, and he took on baking because he didn't feel like he can be a police officer ever again. So the doctor's saying he has to do an ACDF, anterior cervical discectomy infusion, and then he doesn't want to do that. He doesn't feel like that's the right thing because one, his previous surgery, his previous side, the left side, didn't require surgery, and he wants beyond that, he wants to golf and be able to work out again, and he wants to be able to get back to police work. But his doctor, his surgeon, told him that PT would make it worse, and he would have to get this surgery, otherwise his muscle strength would never come back. So he'd been told something that we don't know is true. And furthermore, he can't even visit his friends. This is affecting his life in a lot of ways because he can't even hang out with his friends who are further than an hour drive because he's afraid that he would make his pain worse. And then that would cause him to further lose muscle strength, and that he wouldn't be able to work, and that he would have to get the surgery. So now this is really pervasive in his life. Furthermore, he had COVID in the beginning of COVID last year in March, and now he's deconditioned because he's afraid to exercise, but also because of COVID. He has brain fog periodically, and he has loss of triceps strength, or he said that he did, as tested by the surgeon who gave him manual muscle testing. So those are the main. That's the main parts of his story, and this is what I talked to. I talked to him about 45 minutes to get this whole story, because I couldn't really meet him where he was without understanding who he was, what he's been through, what he thinks is wrong, what he's tried, what his concerns are, because I need to cater my treatment to addressing those concerns, addressing those beliefs, debunking things, reassuring him of things that he's been told, and then figuring out a safe starting place for him. So CC, just so you guys know, is chief complaint. O is onset. MI is mechanism of injury. AI is activity intolerance, which is really his disability. You could think of that as the things that he can't do anymore, or he can't deal with, that he wants to do. And goals are along the same lines, but the goals are things that they explicitly say they want to do. So one is kind of a negative focus thing. One is more of a positive focus thing. The concerns are probably the most important thing. PMHX is just the past medical history. Now, for me, I need to identify what the most important thing is for this person. So a BF stands for a baseline floor. And to me, it's the key link. What is the most important thing for this person for me to address? And for me, I can give him the best exercises in the world, but if he always thinks that he needs to get surgery and his muscle weakness will always get worse, and there's no other thing around that, it doesn't matter what I tell him to do. It doesn't matter, what what is prescribed as treatment, because if his beliefs are that his structural pathology is the final say in all of this, then nothing else will work. So that's the primary most important thing. So it's a mindset that I must change. So I used to, when I was younger, when I came out of school, I would just start trying to treat. I might do some McKenzie, I might do some soft tissue manipulation. If I was really taking a lot of courses, I might even figure out why his he has extra stress going down his left arm, and I might do some exercises. But none of those things mean anything without addressing this first concern. So his key link to me is his structural pathology, and my whole entire case, my whole entire approach needs to be geared around changing that idea. Secondarily, from a competency standpoint, I noticed that he doesn't move very well through his thoracic spine, which might be an upstream physical, biological driver of his pain. But again, the psychosocial is probably the most important thing. Tertiary, that's also biological, is he has diminished work capacity because he's deconditioned. Mechanical sensitivity is what MS stands for. And anytime, so one of the first things I did after we spoke for 45 minutes, I said, okay, just let me show me some of the things that bother you. And, he would try to turn his head, and he showed me turning his head bothered him. So I would say, okay, let me have you, I just did a basic active range of motion screen. So I had to move his head all the way up and back, and that was painful. So in this implies that when I did flexion and left rotation and side bending, none of those things were painful. In addition, when I had him do some other exercises such as a glute bridge and beast and grab, which are things I'll show you, those things also had pain. So these are the things that I need to show him that we can change. Okay, so if you guys are familiar with SFMA, this is a lumbar lock position that shows thoracic rotation. So if you can tell, his left rotation, his right rotation was better than his left rotation. And this is something I wanted to look at just based on what he was describing to me. And this is after looking at that, I took him through a series of exercises where we just take someone through a normal warm up that follows the movement prep ideas that we lay out in movement, first principles of movement, which is we watch how people warm up. We would just watch them move through some basic things, and then we just gather some information. It's a clandestine assessment of how their body tends to function without any excessive coaching or specific screens. So I'll keep coming back to this list of things, but I came up with a bunch of exercises based on this. And this is the list of the exercises. Movement prep is stuff that he would do before he trains and on days where he's not training. And the training is the stuff, the exercises that I found that'll help him both in the short term and in the long term. So I'll go through each one of these and you'll be able to see. So I wrote over here movement prep / Advil because like Advil, you take 2 rounds every 4 hours, except you don't have any negative side effects like Advil, this was shown to remove some of his mechanical sensitivities. I listed his rotation, cervical rotation to the right, his extension, and some of the exercises. So I'll show you a beast, what that is with hand reaches. So this is a beast with a reach, so knees off the ground. Yeah, good. Beautiful. Square it off. Turn the hip in. Yeah, good. Turn this hip in. Left hip down. Yeah, you feel that more in the abs when you do that? Can you count out loud? Good. He couldn't count out loud. He just said, "Ooh, yeah." So that was so I just started him doing some of those things. And I just watched how he was moving, and that helped with his cervical extension and rotation. I didn't film. So these are actual videos that I'm sending the client home with, and so this is after we had gone through all the movements, and I'm just recording this and airdropping it into his phone. I forgot to record this one for him, so I had to record this myself doing it, and then I sent it to him. Five, 4, 3, 2, go. You can ignore that voice. That's the neighbor. Down. 5, 4, 3, 2. Good. So that's just a T4 extension. I mean, a rotation, mobilization of the upper T spine in that dead zone. Oops. Go for it. This is just the crab position. So this is just something that I find that also mobilizes extension. So after he improves rotation on either side, he can improve extension. So this is an extension mobilization that there's no movement. So I just snapped a photo. So this is a beast with a... So after that, I got his upper spine mobilized, maybe got a little scapular stability and protraction going on. Then I just started training him. So He had fear that his triceps strength wasn't going to come back and physical therapy wasn't going to work. But when I talked to him, physical therapy he had been doing, I said, "What'd you guys do in physical therapy?" So they did, easy band exercises, cookie cutter stuff that everybody gets. Um, the amount is just like, you start with the green one and then you move into the blue one. You do 3 sets of 10 and everyone gets the same stuff. But I needed to find the exact amount, the right weight, the right number of reps and sets, the right position, um, that made his symptoms feel better. And that way I can show him, I can change his mindset that a disc means he has to get surgery. Because if I improve his range of motion and his pain and how he feels, through exercise, and I didn't do surgery on him, that starts to change the mindset. So I had to give him something he hadn't done, and I had to give him something that was hard enough, to produce the changes we were looking for. So I started giving him stuff that would make him feel like him again. Stuff that guys like to do, stuff that, makes him feel like he's getting stronger.
Go for it. So this is 20 pounds. We're gonna do about 15. The key is head and neck and trunk stay in place. So even if it makes your arms way more tired, don't let yourself rock, lean. Yeah, you want to be a stature. Yeah, glutes, abs, good. Work them. Done.
So my hypothesis is over time, as he starts to, from based on his story, based on the mechanism of injury, based on all the things he was doing, is when his arms start to fail, he starts to use, kind of lose his upper back, and then he starts to get into like a forward head poking position. So I just choose exercises in the right positions, in the right volume, in the right intensity, is where he trains his arms, trains his trunk, trains his upper back, but doesn't substitute into his neck. So he gets what we call a positive experience of movement, which is our number one, weapon in FPM, is to change people's belief, is to make people, gain confidence that activity is the solution, because we're trying to stem the worldwide inactivity crisis, and we're trying to reassure people that excessive imaging and structural pathology and things like that aren't an end all be all. And the only way we can do that is showing them what they can do for themselves, showing them that working hard makes them feel better, instead of telling them to do less, do surgery, do all these other things, because they have other options. That's what the evidence shows us, but that's not the message that they're getting from, their PTs or their doctors or their chiropractors a lot of times, because we're pushing a lot of things that don't necessarily move the needle on keeping them active or giving them hope.
So this is a tall kneeling triceps extension. That's about 20 pounds. I guesstimated it. This is about 15 reps so far. And done.
So I'm giving him exercises that are changing his beliefs more so than his body, but also trying to get 2 for 1 there.
Times rotating the head while holding a side plank.
You can see his hand shaking.
Done.
So a lot of times when people have cervical rotation, deficiencies, instead of mobilizing the neck, I just let the shoulder be the shoulder with the side plank, so the head could be the head. So I have them rotate their head and they mobilize themselves.
So this farmer's walk, this is 20 pounds. This doesn't have to be kettlebells, this is dumbbells. The key is you should feel the upper back pinching. And you take them from, 20 yards here, 20 yards there, between exercises. And we can build up your strength this way.
So I try not to over-explain it, but I try to give him some cues that'll help him perform these exercises on his own. And if I got some extension mobility, I want some load to lock it in, because load is the best corrective, and load is a strong enough stimulus to make these things stick. Again, this is about empowering him, not getting him to come back for a million visits. So if I give him the tools and I teach him how to progress, then he can take care of himself.
Trx Row, puffing the chest out, pinching the shoulder blades. Good. Good. Keep the shoulder blades pinched together at the top. Good. Yeah, nice tippy toe. Good. Good. Do about 15 total.
So all the exercises I'm picking, you can think of them as, whatever type of exercises they are, but everything is geared around gamifying, hiding the skill in the drill, gamifying, getting him into a nice upright posture, getting some T-spine extension, and locking that in over time. So I'm not necessarily talking to him about his head and neck, but I'm trying to train it without coaching it too much. So
if it's okay, I'm going to interrupt you really quick. This is
yeah.
this is awesome. We have a couple of questions. So I'm first going to ask Louisa to unmute.
Yeah, I was just wondering if there was a particular reason why you filmed the patient doing the exercise instead of like filming yourself and reusing those videos.
Because everybody has their own, people like seeing themselves doing it. I'm personalizing the dosage, the cues, and everything to themselves. So I think there's a little personal touch there that I think people appreciate. We do have an exercise library, but it's not the same as like kind of getting the coaching and the little details that each person needs, because 100 different people can do the same exercise, and while most people will probably, you can give them the same coaching cues, it's not always the same for each person. So I think it just creates a little more buy-in, honestly.
Okay, thank you.
You got it.
Great. And then we have one more question from Mandy.
Okay. So, hey, Ryan.
Hi.
So I had a quick question for you about, I noticed in all of the videos you're using kettlebells.
Mhm.
And I was curious if there's an advantage to using kettlebells versus using the same weight in like a standard dumbbell.
Yeah. So in the current exercises that I have, that I gave him, probably not. One of the things that I do believe in is that the sensory motor access requires good, in other words, good movement requires good sensory input. And good sensory input, if you look at the homunculus, most of our information comes in from our hands and our feet when it comes to kind of like gross movement patterns. So we really believe in stimulating the hands and the feet to get kind of higher quality movement. So something that's really popular nowadays is FRC. And in FRC, how do they create mobility? Well, they really enforce clenching the hands to irradiate. And irradiation gives you a better closed chain exercise, which creates stability and ultimately takes the e-brake off of certain joint movement patterns and allows you to have more mobility and more stability. So for me, I usually like kettlebells for things, let's say like a goblet squat. People's hands might be underneath the dumbbell, but that's not as much hand contact and grip strength and irradiation as you might get from holding a kettlebell. So in general, I like using those things. But these particular exercises, could have used a dumbbell. And I did stress that to him because I didn't want that to be a barrier. Oh, I don't have kettlebells. I don't care. Grab a dumbbell. Grab anything, really. So yeah, hopefully that's helpful.
Yeah, thank you. That's definitely helpful.
Yeah, and sorry, and just one more thing on that is we really like that more with we really stress that with the feet. The feet is really if you look at the function of the foot and the structure of the foot, is there's so many bones and movements and joints and muscles in it because it's supposed to move. But when we walk on even ground, we don't place that demand on the foot to move. When we put our feet inside of shoes, we don't demand our shoes to have to adapt to the ground. And because if you don't use it, you lose it. Our feet start to get less sensory input in, less, less adaptability, less function, less everything. So we really stress that for the feet. And that's why a lot of times you'll see us training with our shoes off, socks off, and things like that. And yeah, I think it's important. Any other questions? Good. Okay. So I'm going to continue with this, if that's okay. And so the summary here with as to the program that I wrote for the person was it was not designed to just give him exercises to do. It was designed to change his belief that every hurt equals a harm. That anytime he felt any sort of pain, he had to stop moving because it was going to make his situation worse. And if we did a bunch of exercises and something that was painful, cervical extension, as well as cervical rotation was less painful, after we did the exercises. The numbness and tingling going down his arm was less painful after doing the exercises. The numbness was less, the tingling was less. Exercises that were previously painful, like the glute bridge and the beast position, if they were not painful after doing the exercises, it starts to change his mind that PT wouldn't work, that he had to avoid PT. And I actually gave him, it's fairly logical that if you train your triceps, that your tricep strength could improve. So, if the doc is telling him that his tricep strength is just going to get worse, but he's doing exercises that are combating that, and his goal is to avoid surgery, then I need to show him that there is an opportunity to improve, that surgery isn't the only way. So I needed to show him what we call the clinical audit process. We audit that the exercise we gave was meaningful and helpful to him, because some things take time. Strength takes 6+ weeks to change morphology, but neurology is instant. And if I can change, I don't know, muscle tension in a certain area, the tendency to move in a certain direction and things like that, then I'm going to take advantage of my understanding of neurology and use it in my to use it to my advantage. So I had to back up all these exercises with showing him that it helped movements, with an explanation about why this was possibly helping, why maybe changing your T-spine position could change, the stress in your neck and ultimately the pain going down your arm. And I had to show him how to use this. So there's a lot of studies that show that people don't do home exercise programs, whether they don't understand them, they don't know how to use them. So I had to give very specific instructions, like, listen, some of these exercises you can use as Advil. You can use them daily to help to put it's like a plant, you give it water and light, it grows. So if I put your body in a very advantageous position to heal, let's say like an arm that gets casted, if you do these exercises every once in a while, it'll put your neck in a better position to heal. And that's why I tell them to do it every few hours. But I also need to back that up. I need to give him the harder training exercises, because I know that he's going to tend towards going. The biggest predictor for future injury is previous injury, and he is the poster child for that. You had it on one side, a few years later, you have it on the other side. So you think it's going to come back. In the back of your mind, you're scared. He voiced to me that he's concerned that it's going to come back. This is that he has to get surgery eventually one day. So I need to play the long game, and I need to show him how, if he builds these things up and lay out the expectation that he must train to create resilience against future occurrence, because he can't keep decreasing his demands on his life. He goes from police to baker to not hanging out with his friends, to disengaging in all social behavior, disengaging in any sort of physical stress. He's going to have a host of other problems going down that path. I can't have him live in a bubble that's going to, if you use it, you don't use it, you lose it. So everything's going to start getting weaker and atrophy. And so I need to break that cycle, reassure him, and build resilience. So I had to give him some prescription around that. And then I had to give him some guardrails around how to progress it, because he's not trained in exercise physiology. So I have to teach him RPE. The sweet spot is 6 to 8 on the RPE, where 10 is the hardest thing you've ever done, and 0 is getting a massage or getting your nails done. So I taught him that, if what we're doing now becomes a 5 out of 10 or a 4 out of 10, then add some reps. And then when you add a lot of reps and you don't want to add reps more, you can add some sets, or you can add some weight. And I was able to get some buy-in by showing him that there was a plan behind this, and not just do this, it's some magic trick, you'll feel better, and he'll fall into the same cycle. And even worse is he'd think that exercise doesn't work because he tried exercise, because I wasn't a good enough communicator to show him how he's supposed to be using it. This was still not good. So it's not like everything we did magically made everything disappear. There are certain things that didn't feel good still.
So this is called a scapular press up. Hold for 2 at the top. Shoulders are allergic to the ears. 1, 2, good. Count out loud. 1, 2, good. Switch. And that's a breathing thing. It's not because I'm trying to, I just want you to be able to enunciate.
1, 2.
It's different on that side, right?
Yeah.
Even your ability to.
1, 2.
Good, last one.
1, 2.
Done.
Can tell his voice is labored, and right rotation was a little worse. Right cervical rotation was painful. I might hypothesize he's not as strong on that right side, maybe through his history, whatever it is. I don't know, but this was ultimately painful afterwards. So not everything I did made him better, and maybe if I coached him like crazy, he wouldn't go into such a slouch and stump, and maybe that would take some pressure off his neck. Maybe not put him into so much thoracic kyphosis, which would, in theory, put some excessive extension on the cervical spine and make his symptoms worse. So I wasn't ready to send him home with that. So that was still painful. But that's a target for the future. If he's doing his home exercise program, that should get better, right? That's the next goal for him to progress towards. Because if he can do that, maybe he can do push-ups with integrity, and then maybe he can do bench press, and then maybe he can do all these other things that I'm trying to build him up towards. Because right now he's in a bubble, right? I need to have goals for him to progress towards. And now, even though that's not better now, I know where to start next time. So very important for us at FPM is communication, getting to know our clients, understanding that we have a collaborative plan, that their concerns are addressed, and that they believe in what we're trying to do and what we're trying to do together. And how we do that also is debriefing with our clients. So it's not just, this is not a transactional relationship where you pay me money and then you come in, and then when you're done, you leave. It's more of a relationship. So we want to debrief with our clients. So I said, good, bad, or ugly, I want you to tell me how you feel tomorrow. And if they don't message me, I'll message them. So I messaged him. So I asked him how he's doing. I don't ask him about his pain. I don't ask him about his symptoms. I just want to know who he is and how he's doing overall. And if he wants to tell me about those things, if that's top of mind, that's what he'll tell me about. So he said he's good, a little sore from the exercises, but his neck feels okay. Part of the reason we do this is we need to know that in the moment, the audit feels good, but the next day the audit needs to feel good too. Because sometimes something might be good in the moment, but it might be too much too soon. And kind of like DOMS, and we won't know till the next day. And if we don't debrief, then sometimes people will get pushed over the edge. They'll be in a lot of pain. And then because we never communicated about it, they'll just think, oh, this isn't going to work. And then we'll never hear from them again. And sometimes we think, oh, they just got better. Or sometimes you're like, I don't know what happened. But this way we can at least address their concerns, maybe reduce the volume, do something like that. So, I followed up with making sure he understands how to use the exercises. So he understands how to use them. This is exciting him and motivating him to go to the gym on his own. And that's my main job, is to change his behavior, to motivate him to want to do these things for himself. Because we all know that it's not sustainable for me to just coach him every day and take him through that. So this is a little while later. He talked about what he did. He understood that he could increase the load, and he had minimal discomfort, no discomfort with the exercises. So he's starting to buy in that he can change his strength, because if he didn't think he could change his strength, he wouldn't try to go up on the exercises, right? And then now he's messaging me on his own. So I didn't message him. This is, a screenshot. He's moving his muscles up. His weights up. And then good news is he saw another neuroradiologist, and he got some anti-inflammatories, which is great, because if it was inflamed, it works. That's fine. Nothing wrong with that. It's a person-centered thing. I don't want him to not get any treatment if they thought it's appropriate. I'm all for that, as long as he doesn't think he's doomed for surgery no matter what. Good news is this doc, even though he remarked on how bad the structural pathology is, which is kind of scary, unless he told him that the worse the herniation, the more spontaneously it recovers. This guy did reassure him that PT would work. So we're going down the right path. He's starting to have hope. So, I basically reassured him that the soreness and discomfort that he had is normal. I encourage him to go further. And then I want to check in on his AIs, his disabilities, the things that are stopping him. The pain stops him from doing his valued life activities. And to him, that was golf, training, being a baker, being a policeman. And also he did mention specifically driving to see his friends. So I wanted to ask, and this is what it's about. It's not about lifting more weight. It's not about having more range of motion or passing your SFMA or swinging a kettlebell. It's about his actual disabilities, valued life activity. So he was able to do what he wanted to do. Yes, it wasn't perfect, but he just needs reassurance that that's the path he has to keep going. And that's the case. Hopefully that's helpful. And I'd like to take questions, and hopefully we'll have a nice discussion about this.
And at this point, if anyone has questions, feel free to unmute. I think the group is small enough to where that's fine. So feel free to unmute if you have any questions.
I just have a quick one about DOMS, because you said that it can happen that the patient doesn't come back because they're in pain afterwards and they don't know why. Do you educate about DOMS and what it is and why it's okay before the patient leaves, or do you think that that'll make them anticipate pain or make it worse if they have not been there, done that before?
That's amazing. That's a great question. I think most people know what DOMS is, and I think they know it's normal and not anything to worry about. But I like where your head is at, because what you're doing is you're trying to anticipate and what they may feel, and you want to lay out expectations, and that is the goal. So if I thought someone was scared of DOMS, if someone told me like, hey, I used to work out and sometimes I'd be in pain afterwards, and I'd be so sore that I wouldn't move for the next few days, I might try to explain to them maybe DOMS isn't where the goals are. I'm really trying to get in front of someone who's in debilitating joint pain or their symptoms are worse. And that's what I might educate them on. I might tell them listen, this might feel great in the moment, but I want to hear from you, good, bad, or ugly, because the next day, if it's worse, it's not the end of the world. It might mean we did too much, and I might reduce what I prescribe to you, reps and sets or frequency or something like that. But I won't, I don't think I'll talk about it from the perspective of muscle soreness. But yeah, I mean, muscle soreness is generally good. I think people feel like they're progressing when they have muscle soreness, because usually they've been told not to do anything and that activity is harmful. So when it's not. But I like your thought. I like also what you're doing is you don't want them to be pain searchers. They're searching for pain all the time. You don't want them looking for the pain, because it's not about the symptoms, not about the pain. It's really about how the pain affects them. So some people, I say, even if it hurts, certain times you have to move forward. So I don't want you to think about pain. I want you to think about function. Great question. Thank you. Are you from Wales? Did I get that?
Yeah, well, I'm from Germany, but I study in Wales. Yeah.
Oh, amazing. Super international. Awesome. Thank you for your question.
I have a question.
Sure, John.
Hi, Ryan. You talk about when you were going through the discussion of the case, you were talking about your hypothesis, right? And you never mentioned a differential diagnosis at all. So why do you do that? Look to hear about it.
Because I think I'm focused on what I can do for the person. If I don't know if I really care whether, the first thing is I have to roll out any red flags. That's the most important thing first. First, I have to roll out any red flags. And if there's no red flags, then I can move forward. So that's super important. So you have to know your red flags. And that was a part of my assessment process. But from there, anytime that I can improve function, decrease symptoms, then that's what I'm interested in, because it focuses on what I can do for the person, what they can do for themselves, and a path forward. But giving someone a diagnosis that I can't do anything for, I would conclude to tell them to refer out and go to someone who can deal with a specific diagnosis like that. But giving someone the diagnoses or the pathology without giving them a solution doesn't help, because they already know they have pain. They already know they have problems. They already know that they can't do what they want to do. I didn't see any real differential right there that I thought was necessary. I very rarely talk about diagnoses, because I think it's harmful, more harmful than good. I think I need to focus on what I can do for them and what I can change. I'm into providing solutions, not problems. So even like the assessments I give people, like I don't like giving people assessments I don't think I can change. So I'm looking for solutions, and everything I'm doing is based on providing a solution, not a title, a pathology, or a problem. So did I think it was anything else? No, I think it was fairly clear. I think he had gotten it. I did a thorough enough history. He had gotten imaging. He had seen another doctor already. This behaved, I mean, it was his neuros, it was behaving like a C7 issue, and none of it was red flaggy. So I didn't think I needed to focus on that. But that's a very good question. Don't forget your red flags, because the worst thing you can do is try to help someone when you're missing the boat on it completely, and that's dangerous. Is that helpful, John? Great.
Hi, Ryan. I had a
Hi.
question.
Hi, Jennifer.
Hi. In working with this client, about how long did it take for you to feel that you were breaking through that psychological barrier, or do you feel that it's still a work in progress?
So just so you guys know, since then I only seen him once. He drove from pretty far away to come see me, and I didn't really follow. I never saw him again, but I had been messaging with him, and he'd been getting better. He said so. I think I started making progress probably about 30 minutes into listening to his story. We know that well, I think 10 years ago, 20 years ago, we knew that doctors cut off their patients within 15 seconds. And then a recent study showed that I was really closer to 10 seconds. So I just let him speak about, give his story like Peter O'Sullivan teaches. And then he started discussing everything he had been through, what he was so worried about, what he thought was wrong, why it was affecting him, what he wanted to get back to. I just asked him what he thought, was helpful, what he didn't, what his real fears were and how it would affect him and things like that. And just being heard has been shown in some research to start to reduce symptoms. And then from there, I think once he started to see certain movements that were previously painful just mere seconds ago, he started to realize like, oh, I mean, if this disc was something that needs to be cut out, then he didn't cut anything out of me. So why do I feel better now? And then following up with that was explaining why that worked and how to use it. Then he starts to go, oh, okay, like that makes sense. That matches his lived experience. That matches what he just felt right then and there. Because if you really listen to what he said, he had been through this before on the other side and he didn't get surgery. Yet this surgeon is telling him to do it right now. So you already know that he's skeptical of the situation. So he's grasping for hope. He's looking for someone to tell them that it's okay and that he can do something about this. Unfortunately, other PTs he had gone to who wasn't giving him the result he was looking for. But if I listened to him closely enough, he wanted a reason not to do surgery. And I needed to understand that he was fearful. What he was fearful of was that his strength wouldn't come back and that the only thing he could do was surgery. So that's what I said. His key thing is a mindset that I need to shift that. And once that started to happen, he started buying in. He started getting excited. And then he starts sweating. Oh, I'm working on my COVID deconditioning. I'm working on my work capacity. I'm getting stronger. I might be able to become a baker again. I might be able to be a policeman again. I might be able to do this. So that's why in First Principles of Movement, we talked about giving someone a positive experience with movement. And then if you take it further, Dr. Craig Liebenson's mission statement at LA Sport and Spine, which is his practice, is to give people tangible hope, positive experience with movement, tangible hope, and achievable plan. So I needed to give him hope, and I needed to explain to him what we were going to do and what to expect, how to approach it in the long term. Is that, hopefully that answers? I know it's a little long-winded.
Well, that was great. Thank you.
You're welcome.
Can I pop in a question?
Absolutely.
It's a bit of a long-winded question, but it comes in two parts. The first part is from a therapist perspective, what do you use as an indicator or a a means to evaluate, your loading, your repetition, your load progression when in a therapeutic program over a longer period of time. And when you're approaching the psychological barrier, do you, implement some form of like cognitive behavioral therapy or anything like that to try and facilitate breaking that barrier?
That's awesome. Thank you, Kyle. I just want to answer the second one, but the first one is, uh, it goes back to the gap analysis, right? So you're asking if I got this right, how do I know how to choose reps and sets and load and that kind of stuff, right? Is that the
Yeah.
gist of it? So it starts with what Adrian led off with is what's the gap analysis. So I want to look at what they have and what they need. So as a police officer, I say, what are the demands of a police officer, right? You got to have strength, you have to have endurance, you have to have mobility, you have to have agility, you have to have power. You basically need to be able to get into a fight, or you need to be able to chase someone. So I think about all the qualities that has, and then I look at what he has, and I said, okay, how do I start to build towards that? And then if I study, let's say, Russian sports science, I say, okay, in the first training block, before I start trying to get someone strength and agility and all that stuff, I need to just have basic fundamental work capacity, basic fundamental competency and conditioning. So I'm picking higher reps and sets because I need to build up work capacity, which is why it was a tertiary thing. I also needed to build confidence. So if I give him too much load, too much too soon, and it puts him over the edge, I can't get him fit in one day. I can F him up in one day and break his will and break his hope in one day, but I can't get him fit in one day. So why take that? It's like risk versus reward. I need to build up confidence. I need to build up work capacity. I need to build up strength. I need to make him feel like he was working hard. So I'm looking for, so that's why I chose higher rep sets, lower loads, higher number of sets. And I back that up with RPE. So he needs to say that he's somewhere between a 6, 7, or 8. If he's less than that, I say, hey, next time maybe do a little more. If it's 9 or 10, I said maybe it's too much too soon. But I probably would have figured that out if he was making faces or if he was hurting. And then I back that up on the back end with a debrief and say, are you sore? Are you hurting? If he's just a little muscle soreness, maybe a little stiffness, maybe a little pain that goes away with a little movement, then that's in the sweet spot. If he's in a ton of pain, it was too much. If he has no soreness, it probably wasn't enough to drive adaptation and physiologic change. Does that make sense?
Yeah.
And remind me again, the second part again?
The second part was regarding the psychological barrier. Do you employ some form of cognitive behavioral therapy in it? How do you approach it? Do you, facilitate the breaking of that psychological barrier with psychological theories or anything like that?
Yeah, absolutely. I mean, all we're doing when we're this type of approach is besides the gap analysis is graded exposure. So cognitive behavioral therapy, some of it, from my understanding of it, is exposing people to feared stimuli gradually over time. So if you have arachnophobia, like you might have like a funny little spider, and then after, it's shown to you, and then maybe like a spider doll, and then maybe trap you in a room full of spiders or something. But over time, you basically expose people to what they fear. And when it comes to exercise and stress, it's the same exact thing. If this guy, thinks that movement is going to harm him, and there's, then I need to give him the amount of movement that makes him feel good. And that's tied to the 6, 7, 8 out of 10 RPE. It's tied to the talk test, which is why I asked him to count out loud. He had a labored voice on one side versus a loud and clear voice on the other side. I can tell that he's starting to break down. So I can't do too much direct neck stuff if he thinks it's going to worry him, cause him trouble. But if I think it's going to overload him, I'm going to give him an amount that I think is going to make him feel better. And so I'm going to expose him to loading, which he doesn't believe can help him, in a small enough amount that changes his mind. So, yes, exposure to feared stimuli. Also, what we do is we try to capture the yellow flags. So there was a study of a questionnaire of 13 yellow flags that predicts where acute pain might become chronic and be more psychologic in nature, which leads to poorer prognosis, which has to do with people's beliefs, their concerns, their how much they think hurt equals harm, how much they think they're on the right path, how much they think that there's an opportunity to get better. And if all those beliefs are very low, 0 to 10, 10 being not very low, then it's my job to focus on improving those things, improving hope and all those things. And that many times is more important than the biological stuff. So I need to capture that with the yellow flags questionnaire. And that's part of our intake process. And that's part of how I knew that his most important key link was changing the belief that hurt equals harm and structure equals doom.
Thank you.
That was a great question. That's something that I've learned from Dr. Liebenson that he's published on. That's part of Rehab of the Spine textbook that many Kyle, are you a chiropractor?
Yeah.
Yeah.
Well, I'm not not just that. Yeah. It's
Soon,
my current.
all of you. Yes. Soon. So if you have Rehab of the Spine, it's even in the first edition, I think, but the third edition definitely has it. So a very, very important and underlooked thing, because we know in society, most of the musculoskeletal pain does not revolve around traumas and acute injuries. Yes, that happens. Yes, we need to know how to work with that. But so much of what we deal with is chronic pain, and chronic pain is its MO is having the wrong education, the wrong activity. You know, our most important tools are education and activity modification, whether it's adding more exercises or taking away stressors or improving recovery, and then re-educating. So, it's something to think about is you want to include that in your intake process, whether it's written or through asking.
Thank you.
You're very welcome.
Can I ask a question as well? And I think you sort of touched on this in this past question, as well as with Jennifer's question. But I was thinking about how the patient initially came in and said that they were told PT would actually be harmful to them. And like with this patient or with any other patient, what is your approach and where do you start with patient education for a patient that comes in with that belief?
That's a great question, Amanda. That's it's where it starts from is listening to the person. I can't jump in and start talking to them about things related to the evidence if I can't relate it back to their story. So if I don't understand why they so strongly believe that, or if I don't understand why they're coming to me in the first place, we have our own beliefs about what we do and what we're there for, but I don't know what his expectations. I don't know if some people come in, they just want to know like something simple like what's safe and what's not safe. Some people are looking for us to magically remove their pain. Some people, are scared of surgery. Some people think that a massage is going to help, is the cure all end all, or an adjustment is the most important thing. And I can't start targeting the education process without understanding what they've been educated on. I can't de-implement and de-educate without first understanding what has been educated on. So that's the first step to person-centered care and education, is de-education of harmful beliefs and things like that. So it's a little cliche, but that's why we spend 30 to 45 minutes on, or maybe it's not cliche. I don't really know what they're teaching in schools, but we have to take the time to get to know the person. That's the most important thing that we can do. And in my practice, we spend 2 hours on the first visit, and we don't even start moving until 45 minutes or an hour after they've heard their story. And we don't cut them off. We don't over explain. We don't jump in, because there's all these things we know and we want to explain. But the more I find that the more I listen, the more I can cater my explanation to the person. Does that answer your question, Amanda?
Yeah, that's helpful. Thank you.
Yeah. And, I would say it's also very helpful to know the evidence. If you can cite like certain things, sometimes people believe you, and feeling is believing. So if you do a great job of making them feel what you're trying to get across to them, they'll believe it. But sometimes people just want to read it. Sometimes they just want to know. You might want to if you have a stash of evidence that backs you up, a lot of times it helps.
All right, I have 2 questions.
Absolutely.
The first one, how would you explain what's wrong with the patient in this particular case?
That's good. So do you want me to answer first and then you ask the second one?
Oh, okay. I'll just go ahead. So how would you come up a prognosis for this particular patient? And is there any strategy to come up with a good prognosis?
Yeah, those are both awesome questions. So, so on the prognosis front, you have to know the evidence, right? So, when Dr. Liebenson and I hosted Lorimer Mosley on our webinar series over the summer during COVID, he said, we don't know. We don't know everyone. That's the $1 million question. What's the timeline? What's the timeline? With chronic pain, there is no timeline. There's maybe some landmarks. I don't promise. I don't try to overpromise and say I'm going to, you're going to be done in this amount of time. I just say that if you're doing these things and you're seeing these kinds of results, like let's say you're able to tolerate more driving, then we keep doing more of what works and we keep doing less of what bothers you. And we see how far we can get. So it's not what people want to hear, but that's what I might say. On the other hand, things like tendinopathies, we know it takes more than 6 months. So I don't even bother auditing as much or trying to tell people that this is going to go away. I find that shoulder injuries take a lot longer because so I might give people longer prognoses, but I like to focus on landmarks instead of timelines. I think it's much more important. Hey, if I see your 3 sets of 15 goes from 20 pounds to 25 pounds and you have no more pain, or even better, if it goes down, then we keep going. We keep going. We keep going. Then so I'll focus on what you can do and things you can achieve and things like that. So that's to me more important because it signifies to me maybe he's more resilient and can handle more stress, physical stress. Sorry, can you come back to the first question again? Can you say it again? Because it was a good one.
The first question was, in this particular case, how would you explain what's wrong with them with this patient? And they want to know what's really wrong.
Yeah, I would say that, so I didn't go too much into the details. I just, I basically described to him that sometimes, the activities that he is describing might lead to more stress on that part of the body than he can handle in the moment. So I try to frame it around his current capacity and being over his the demands of his life are being over his current capacity. So I'll take it back to his story. I'll base it based on what he told me. He said, I was working at a bakery, but it wasn't until Thanksgiving when there was a crazy rush and we had worked 12 hours afterwards, I had all this pain. And that's the same thing that happened to me last year when I had numbness, tingling, and pain going down my right arm. So I feel like it has something to do with that. So I said, okay, well, and then he's deconditioned. He had COVID. He hasn't been training. He hasn't been active. So I said, listen, like when you do a little more than you can handle, you might kind of place stress there and kind of set something off. And I frame it that way because that allows me to frame the solution around building strength, building resilience, building capacity, and helping him have an actionable thing that I think will make him more resilient. So, I would say, discs sometimes get affected by how we use our arms and things like that, but it's not necessarily posture per se, because posture is always changing, but I would frame it more around things that are modifiable because I don't know if I can change his posture. I don't, so everything I do, I know in the back of my head what the evidence says about a lot of these things, but I don't want to get too much into the details unless it's going to drive behavior change because as Lorimer Mosley says, we're in the behavior change game with people in chronic pain. So it's, I don't like talking about structure too much. When people start talking to me about their L5 or their psoas or things like that, I start worrying because I don't know what they've been told before and things like that. But I think what I would advise is to try to base it on things that are actionable and things that drive behavior change. That's a great question.
Thank you.
Both of those are great. All of you guys actually have been amazing questions. It sounds like you guys are coming out of school a lot smarter than when I came out of school, but this is really great.
Hey, Ryan, I just got one question. So in terms of exercise prescription, right? So you give them the exercises, you try and tailor it to them as best as you can and hope that they do it at home. And then say a week later, they message and they're like, listen, I'm way too busy at work. I don't have time to do the exercises X, Y, Z. Would you schedule more sessions with you just to make sure that they're still making progress?
Yeah, I try to, couple of things there. One, if someone doesn't do their exercises, I don't think it's a compliance issue on the client's part. I view that as a failure to show them how important it is that they do the exercises. Because if something was so powerful and so helpful and it was actually going to help them, then I feel like they would do it if they were suffering enough. Like, because people don't come to us when they're in pain. They come to us when that pain threatens their identity, their value life activities and things like that. And if this solution they believed would work, because they really do want to get over their pain and get back to their life. And if they didn't do it, they probably just don't really believe in the plan that much, you know? Yes, some people know so and just need accountability. And maybe they want us to take them through it, but that's something we would talk about. So sometimes when I give people exercises and it looks like they're not too into it, or they don't know what they're doing, or they're not very comfortable with it and things like that, I'll ask them point blank, what barriers would you have to be doing this? Do you have the equipment? Do you have the time? Do realistically, I would say in a perfect world, you would come see me once a week. I would update your program. You'd do this 3 days a week. Realistically, would you actually do that? And if not, why wouldn't you? Right? Is it money? Is it time? Is it equipment? Is it desire? Is it know-how? Do you feel uncomfortable? Do you not, whatever it is, then we talk about it. How can we help solve that? Well, maybe if I sent you home with this thing, is if I made you do this version, do you think that's more likely you do it? Sure. Okay. If I had you come and work in a group, and it was cheaper and more sustainable, would that be helpful? Oh yeah, I would love that. If I texted you once in a while and just checked in, was that helpful? Yes. So for me, it's about the person. There's a million and one reasons. Everybody knows we need to exercise more. It's less about shaming people about why they're not exercising. And it's more about finding out why they wouldn't, and solving those barriers and making it important to them.
So would you do that right at the beginning, or say like a week later when they come back to you and said, like, I didn't do it this week?
If they came back and they didn't do it this week, I would say, hey, would it help if we met more often? And then I might schedule more. Yeah. I mean, I try not to. Nobody, and they don't want to. They don't want to. I cost too much money, and I take too much time. I spend way too much time with people, and I cost too much money. So usually they don't want to. But some people, if they really, really want to, then I will do that with them, or have them work with the trainer on our team, or things like that. I won't do it off the bat. Like, I won't necessarily tell someone right off the bat, like, this is going to take twice a week visits for 8 weeks, unless I really felt that's what it would take. And that might take a little experience, which is probably hard for you to imagine how to decide that right now. But I think over time you'll see how your explanations work, and how people respond to what you're telling them and teaching them, and then you'll adjust accordingly.
Awesome. Thank you.
Thank you so much, David.
This was great. And I think if you let us, we would ask you questions for another hour and a half, 2 hours. But I want to be respectful of everyone's time. I know some people, Allison and Louisa, it's like midnight. It's like past midnight in Wales already. So you guys get the gold star. Kyle, I know it's a crazy time for you as well. But because I know there are many questions left to be answered, can you let us know what is the best way to reach out to you with further questions that I'm sure we have?
Yeah, I think probably the best place is, I'm just going to type this in right now. My email address is ryan@reloadpt.com. If you guys do Instagram, sometimes I'm scrolling to just kind of goof off and get my mind off things. I might see a message there. Otherwise, I think the Facebook discussion group is a good place as well. And I would love to meet you guys in person one day in a live event, or maybe through the mentorship. That would be great as well. We do a 3-ish month mentorship where we take you guys through this clinical reasoning process, and how, you have access to ask us questions, and we discuss and we do things like that. That would be great as well. But I love that you guys are asking such great questions and so interested at this early in your careers. And I hope we can continue to interact. I really appreciate all the people coming in. I saw Wales, South Africa, all over, North America, everywhere. So I really do appreciate this. And yeah, please contact me. I'll post up more cases too through the Facebook website and through Instagram as well. And please comment on there as well. And hopefully we stay in touch.
Great. Ryan, thank you so much. I really appreciated from start to finish, you expressing your commitment to fighting your own biases. It's a display of your humility. I love your take on the case study as a person study rather than a case study. And I love that Advil analogy. I think that's going to go viral. I think that's dope. What was Advil? It's like Advil, do them twice a day, every 4 hours, or
take 2 every 4 hours.
Take 2 every 4 hours. Yeah, I love that. It kind of reminds me of the cough drop analogy, but for something active. Yes. Love it. Thank you so much. We hope that you will come visit with us again. And thanks everyone for joining. If you are not currently a member of the FPM Student Working Group, I just posted the link in the chat. Feel free to submit a request to join. We'd love to have you. We meet every 2 weeks via Zoom for these kinds of active conversations, again, focused on knowledge translation. So 2 weeks from now, we're going to be discussing a great podcast that I'll post tomorrow in the group. 2 weeks from then, we're going to have another case study. And 2 weeks from then, we'll have our next guest speaker. So thank you guys for joining. Thank you, Ryan. And hope you all have a great night. Thanks so much.
You're very welcome. Take care.
Thank you so much.